Thank you, Diane, for sharing your personal story about your dad. It's always hard to talk about, but it's a really, really important point because we see people often in the emergency department with their life-limiting illnesses who are suffering with different symptoms, and it's a really good time to talk to them about what's important to them and to make sure that our goals of what we're doing align with their goals. And we often don't ask patients what their goals are. We sort of assume that they would want everything and they want to be in the hospital again. They were just in the hospital last week. And sometimes the answer is, I really don't want to be in the hospital. And I don't want all this stuff. So it's a good time to have that conversation. Okay, we're going to completely switch gears and talk about trauma. So my goal here in the next 30 minutes is to talk about how to do a good trauma exam. And one thing about patients who come in with trauma is that you have to be organized. It's very easy to get distracted by the various injuries they may have or the complaints they may have and forgetting about the things that may be hiding underneath what they're presenting with. So we're going to talk about the trauma exam, and I'm going to start with just talking about ATLS a little bit. If you didn't know, there was a recent new update of ATLS. There's a 10th edition now, so this picture of the 9th edition is out of date now. But ATLS has been around for a long time. And ATLS was originally started by a surgeon who had a bad experience. It was a guy who was in a plane crash with his family out in the Midwest and found that the local hospital where they went really wasn't prepared to deal with the type of traumatic injuries that his family had suffered. And so eventually this evolved into the American College of Surgeons starting ATLS, Advanced Trauma Life Support. How many of you have taken ATLS at some point? Okay, good, a lot of you. And whether you work at a busy trauma center or you don't, trauma patients present everywhere. In fact, probably 80% of all the trauma in this country goes to level 2 or lower trauma centers. So it's really important for all of us to know how to do a good trauma exam. What ATLS offers us is a common language for us to speak with one another about trauma care, whether it's nursing, whether it's a surgeon, whether it's an anesthesiologist, whether it's an emergency provider. We all know what a primary survey is. We know what a secondary survey, we know what those things mean, and we know how to get through them. And if you haven't done a lot of these or haven't done them in a while, I want to share with you some of the pearls. I work at a big level 1 trauma center. We do a lot of trauma care. The kinds of things you want to think about as you go through your trauma exam. So yes, it's an ABCDE approach. That's true, similar to what we learned for ACLS, but underneath that ABCDE, there are some different things that we need to think about and different priorities to keep in mind. So in terms of an overview of a rapid trauma exam, remember that we start with the primary survey. We're going to start with our ABCs, and no matter what they're complaining about, no matter their eyeball hanging out over here, the leg, we're going to start with A. That's what we start with, because if we don't have A, we're not getting anywhere else. So we want to get through a primary survey. We want to get through airway. We want to get through breathing. We want to get through circulation, disability. And we want to get through these things rapidly so that we can move on to our secondary survey. And after that comes our definitive management. All of this needs to be done quickly, right? We need to get through that primary survey quickly, especially in the patient who looks really sick. But it's very important for us to get through this systematically. Now, in many places when we have trauma patients coming to us, we have time to prepare. We are notified that a trauma patient is on the way via EMS, right? When we have those few precious moments to prepare before this sick patient arrives, there are things we need to think about. There are things that we need to prepare. And this preparedness stage is the key to success, having all your ducks in a row. So things to think about. Do I need blood products? In a lot of places, that means notifying the blood bank that you might need blood. If it sounds like that's something you might need, giving them a heads up can be quite helpful. Do you need airway equipment? Does it sound like you might need an airway? Does it sound like it might be a messy airway? Do you need your backup airway equipment available? Have it there. You don't want to be searching for it at the last minute. What kind of consultants do you need to notify? Often we don't have those consultants really at the bedside in the emergency department. So who do we need to give a heads up to? Letting everybody know, this is really important in the local environment, to let everybody know what it is you want people to do. This is a lot like ACLS training. This whole concept of team communication is just as important, if not more important, in trauma. So everybody to know what their place is. What is it you are going to expect them to do? What are you going to be doing? So making sure that you decrease the chaos among the team members and knowing what their roles are going to be. Don't forget about personal protective equipment. Often this is something that as they roll in, you're like, oh, I should have had a face shield, as they're vomiting. So have your personal protective equipment ready to go on. You don't want to have to leave the room to go and ask for that. And then do you need to notify radiology for any portable films? Are you going to be, it sounds like you're going to need the CT scanner, letting them know that, hey, we've got a patient coming in. Most of the places, if you see a lot of trauma, you have protocols to get this stuff done. But if you don't see a lot of trauma or it comes in infrequently, thinking about these things and having them prepared prepared can be really the key to an efficient trauma resuscitation. Now, trauma is certainly a team sport, and you need help. You need help moving the patient. You need help getting all the things that you need to do in a timely fashion. So calling resources to the bedside and, again, defining what everyone needs to do is a really important part of that team sport. And as the provider, we are the leader of that team. We need to be the ones that are designating what everyone's going to do. And this team leader concept is really important because we need to not just organize, but we need to assimilate the physical findings for our team. So for example, when you're running a trauma case, you want to be saying out loud what your findings are, what your thought process is, what you're seeing with the airway, the breathing, the circulation, so that all the people in the room know where we are in the primary survey and what your findings are. And often you have perhaps a nurse who's writing down or taking notes in terms of what kind of findings you have. So all of this needs to be articulated. And as you're going through the primary survey and finding abnormalities, you need to decide what you're going to do about those. And in general, we need to assimilate for our team what our decision making is going to be. And as that patient decompensates or dynamically changes, all of these things need to be verbally articulated. And often this is a little different than how we see a lot of our other patients in terms of narrating what we're doing with our patient in front of us. There is going to be chaos. And often in trauma cases, because they can be very dynamic, chaos will evolve. And our role is to stay calm and to continue to be that leader that everybody's looking at. If you are starting to panic and get nervous and your voice is going up and you're talking faster, people in the room start to get nervous with you because all of a sudden they see, oh gosh, this person must be really sick because she or he looks really nervous. So our energy in that room has to be calm and organized because that encourages the same from all of our team members. Often trauma patients can really decompensate. Things can happen dramatically. And that's why we have to go back to our primary survey, go back to what we know. If something changes, go back to the beginning, go back and reassess. Where is it that I need to act? What do I need to do? So before we get started with the specifics, remember that in terms of a primary survey, we want to get through a primary survey, a quick ABCDE, in about 15 to 30 seconds. We want to get through those primary elements quickly so that we can identify any potential life threats up front, but not miss anything along the way. And if you find a problem in your primary survey, the idea is to temporize it. I'll tell you more about what I mean as I go through the ABCs, et cetera. But you want to temporize it in the moment so that you can move on to that next step in your primary survey, because every step in the primary survey is important. And the sicker the patient is, the more you have to be organized and stick to your ABCs and not jump ahead, not jump around, and risk skipping, missing that pneumothorax, missing that type of injury. So don't get distracted. Stick to your primary survey. So here's kind of an overview to me of what a rapid trauma exam looks like. You've got the patient arriving. You've got EMS giving you a report. You're going to transfer that patient to the gurney. That's going to take a few seconds, right? That's part of what we have to do as well. It's a really important part because we need to know what the accident looked like, what the mechanism was, all part of our decision making. Then we want to get to our primary survey. If we have ultrasound, that's going to include a fast exam, a focused assessment, sonography, and trauma. We're going to include that there. Then we need to log roll our patient using C-spine precautions if appropriate. We want to examine their back, plus minus rectal exam. We'll talk about that. That's going to be maybe another 15 seconds or so. And then we're going to move on after that to our secondary survey, getting some more history, our ample history. We'll talk about what those letters stand for. And then we're going to package that patient for CT scanner or the OR, the ICU, IR, wherever they're going next for the definitive management. They're going to move on to their next phase of care from there. And all of this could happen ideally in about 10 minutes. And these will really encompass the resuscitation and stabilization measures that we need to do. In a very organized way, should we streamline all this, and we had all the team members we needed, this does not have to take very long. So let's start with our primary focus. We get our patient on the gurney, and we're going to start with A, the airway. And remember that we need to always be protecting the C-spine. If there's any question about whether there could be a C-spine injury, that is a very, very high-risk thing. So if any question, default to protecting that C-spine, and certainly in terms of assessing and managing airway, keeping that C-spine and those precautions in mind are very important. So we're going to assess the airway. What's the fastest way to assess someone's airway? If they're awake, we're going to say, how are you today, sir? My name's Dr. Shoenberger. How you doing? Would you remember what happened? And if they're talking, airway's patent, right? That's the fastest way to assess their airway. Let's say they're not conscious, can't answer my questions. Well, then I'm going to describe what I'm seeing, and I'm going to describe this out loud. I'm going to say if they have snoring, or if I hear any stridor. Do they have a gag? Do they have a foreign body in place? You want to describe what that airway is like. So sonorous respirations, gurgling. Do I need some quick suction? What kind of temporizing measures can I do? So things that I can do are, for example, repositioning that airway, keeping in mind my C-spine precautions. Perhaps they need a quick jaw thrust. Maybe they need a little suction. If they're really not breathing at this point, I'm not going to stop and do a full intubation right now. I can do a bag valve mask with an oropharyngeal airway and say I'm going to prepare for intubation, but I'm going to complete my primary survey before I do that because I don't want to miss what could be down the line. So temporizing measures here for the airway. Oxygen, of course. Definitive measures, I'm going to say I'm going to get my advanced airway equipment to the bedside, whether I'm intubating, whatever I'm going to use. I'm going to articulate what I'm thinking about, and I'm always assuming that there might be a C-spine injury. Okay, if I get past my airway, I'm going to move on to the breathing. This is where my stethoscope and my hands move down to the chest. I'm going to listen. I'm going to observe for chest rise and fall. I'm going to quickly palpate the chest wall. I'm going to listen to those lungs bilaterally. Are the lungs clear bilaterally? I'm going to say lungs clear bilaterally. What does that breathing look like? Is there any sign of respiratory distress? Do I feel any crepitus in that chest wall? Now, if I don't hear lung sounds on one side, I'm pretty sure that there's a pneumothorax there. If they're really, really sick, if I think it's a tension pneumothorax with hypotension on the screen, and I have to do something right now, I can needle decompress. That would be my temporizing measure. Most of the time, we're able to kind of sit on it and decide what we're going to do next and move towards definitive treatment later. It's very rare that we have to do in the emergency department any kind of needle decompression because we're going to get through this primary survey quickly, and I'm going to get back to that decreased lung sound on that side in a short period of time. Definitive measures here for the breathing. If I think there's a critical problem at this stage, I'm talking about a thoracostomy or a chest tube. I'm talking about intubation to assist those ventilations. Other objective measures of B are to look at that respiratory rate and the pulse oximetry number. Those are going to be my objective measures of what B looks like. Now I'm going to move on to C. Okay, my breathing's intact, my lungs are clear bilaterally. Now I'm looking for signs of shock. I'm going to palpate my pulses ×4. I'm going to look at my skin signs. If I have any kind of hemorrhage happening, I'm controlling that with pressure. I'm establishing IV access. If I'm having a hard time getting an IV, I'm considering going to an IO at this point in terms of my resuscitation. And in terms of the temporizing measures for C, again, I'm going to put direct pressure. I may put a tourniquet up if I have a life-threatening type of hemorrhage or amputation. I can put in temporary sutures or staples if I see a big scalp laceration that's oozing the bed. I don't have to definitively manage that right now. I can put in some quick staples or a figure-of-8 suture to tie that off so that they're not oozing blood and oozing blood and oozing blood as they're sitting in the emergency department and going to CT scan, et cetera. It's a really common miss. We want to get some attention to that. If they need IV fluid resuscitation or initial blood resuscitation, I'm kind of thinking about it at this point. And then definitively, how am I going to deal with the issues that I see in this category? This is someone who might need IR, may need to go to the OR for definitive management, or a laceration repair when I get to that phase of their management. My objective measures of how C is doing in this patient is I'm looking at their blood pressure and I'm looking at their pulse. And I should have those numbers by now in my primary survey. Now, depending on where you consider the ultrasound to fall in your trauma resuscitation, I think of it in C. I think of it as sort of the internal measure of circulation and whether there's hemorrhage present. So this is often where I'm including my fast exam, and I'm looking internally for any kinds of positive signs of blood. So this is where I include ultrasound. Some people include ultrasound at the end of their primary survey. This is sort of where I think of it, because I think of it as the internal measure of circulation. So how about D for disability? Are we doing a full neuro exam? No, of course not. We're doing a very simplified, gross overview of the neuro exam. So I'm looking at the patient's pupils. Are they equal? Do I have a blown pupil? Are they reactive to light? I'm just asking the patient, can you move your hands? Can you move your feet? Do you feel this? Do you feel that? A gross movement and sensory ×4. Rectal exam is a consideration in a select group of patients. We'll talk about that. And then also a measurement of their Glasgow Coma Scale, getting an idea for the motor, the eyes, the verbal score of the Glasgow. Just to remind you, these are how we do a GCS score. We have the motor, the verbal, and the eyes. The motor is the one that has 6 different possible measurements. The verbal has 5, and the eyes have 4 different possible scores. And if you have a 15, you're of normal consciousness, you are able to follow commands, you're appropriate in terms of your verbal response, and you're opening your eyes spontaneously. Probably one of the more common GCS scores we see in trauma is a 14, the person who's normal otherwise, but a little bit confused. They lose 1 on their verbal because they're confused. So that's a common score we see. And then obviously if you're really at the bottom, 3 is the lowest score possible. 3 is the lowest score possible. Now we talk about intubating around a GCS of 8 or 9, and really intubation can happen at any score. There is no absolute indication for intubation depending on your GCS. But as you get down to around 8 or 9, you're thinking about it, because often this is going to be a patient that you're going to be sending to CT or out of your department. And so you're starting to think about whether or not this patient might be going in the wrong direction. So consider intubation in there, but I never say absolutes when it comes to that. I think that there really has to be a lot of individual patient decision making. Now, E is for exposure, so we want to really undress trauma patients. We don't want to miss any wounds or lacerations. This is often happening as we're completing our primary survey. We want to look for any long bone or bony deformities, any kind of odors, any kind of toxicologic exposures. Is there gasoline on them? Anything that we might note there. And then part of exposure is log rolling the patient with C-spine precautions to take a look at the back, look at all the things across the back, the flanks, et cetera, and describing what we see. Being mindful that we want to avoid hypothermia. Often when we do this and we have this patient exposed, obviously privacy is a concern as well, but our ERs can often be pretty cold, and these are patients who could be bleeding. So avoid hypothermia, have warm blankets, etc. So just to review all of that, we've got A for airway. We're looking at our airway, we're describing it, we're assessing it, we're looking at breathing, our lung sounds clear bilaterally, we're looking at circulation, we're feeling our pulses ×4, we're addressing and temporizing anything that we find along the way. Disability, the pupils, can you feel this? Can you move that? A very gross overview of the neuro exam with a quick assessment of their GCS. And then E, really making sure we're not missing anything, and we're really looking in all the nooks and crannies. Particularly important in blunt and penetrating trauma. You know, you definitely can miss the little, gunshot wound, the little bullet trajectory that's in a little place that's hiding. This is the nooks and crannies. You want to make sure you don't miss that. This should really all take about 15 to 30 seconds when you go through it rapidly. Now, in terms of rectal exam, depending on when you took ATLS or learned how to do trauma, long time ago, we used to do rectal exams in everybody. Basically, when you rolled them, we used to talk about fingers and tubes in every orifice. And that's really a little bit kind of fallen by the wayside, because there's been studies to say, how much does the rectal exam really change what we do? I mean, how often do you really need that information? So these days, it is really not needed in every trauma patient. It's part of D and disability. It usually happens during the E part of things. What we're really looking for in terms of a rectal exam is any kind of gross blood that might be a part of a pelvic fracture, any kind of trauma in this area, and rectal tone in terms of a neurologic assessment. The scenarios where a rectal exam might be useful would be a person who has a possible spinal cord injury. That would be a very useful piece of information, particularly before we intubate and paralyze them and may lose that rectal exam. So that's a really important caveat. And then patients who we think might have a pelvic fracture or have penetrating trauma in the lower abdomen, when you're thinking about a bowel or urethral injury, and again, you're looking for gross blood. Those would really be the 2 areas where an actual invasive rectal exam is needed. Otherwise, we usually ask people to just kind of squeeze to show us that that function is intact. So I'm going to show you a quick video of what this kind of a primary survey looks like from beginning to end. Now, my caveat here is that this is a resident performing this on another co-resident. So you may find that their attitude is a little bit sort of on the humorous side, which is not typical of how they treat actual patients. So I want to give that caveat before you watch the video. And a lot of these guys who are in the blue scrubs, we are the designated trauma training center for the US Navy. So we have a lot of Navy corpsmen, and we're very, very honored to work with them, helping, and so some of them were part of this video as well. So we're just going to run through and just sort of watch what a primary survey looks like. Hit the button. Okay.
We got PGY 2 special, drunken head whack. 2 large war IVs, O2 and monitor. Sir, what's your name? All right, airways patent protected, phonating. Any pain here? Chest wall stable, non-tender, no crepitus. Take a deep breath. One more. Breath sounds bilaterally. Okay. I feel pulses, bilateral upper extremities. Pelvis is stable. I got pulses, bilateral lower extremities. Okay, can you look up here? Pupils are pearl. Can you move your hands like this? Move your toes back and forth. Do you feel this?
Yeah.
Do you feel this?
Yeah.
Okay, moves all four extremities, feels all four extremities. Do you want me to keep going? Is this what we keep doing?
Exposure.
Strip them and flip them.
Strip them and flip them,
Right.
Pomeranians.
So you got C-spine?
Let's go,
Keep
Navy.
them in there. All right. Give yourself a big hug. I'm going to palpate your neck and down into your back, and I'm going to put a finger up your butt. Okay? All right. On your count, 1, 2, 3, and then roll.
All right, 1, 2, 3, roll.
Okay. All right. Any pain up here in your neck?
No.
How about down here?
I'm good.
Any pain?
I'm good.
All right. C, T, L spine, non-tender, no step-offs or deformities. Rectal tone intact. Should we bring him back?
1, 2, 3, now.
No blood on the finger. Okay, primary survey done.
All right, so just to give you an example, certainly you don't need 7 people helping you with the primary survey. It would be nice if we had all that help, wouldn't it? But for the purposes of just amplifying that, saying this out loud and narrating for everyone in the room, often we perform our exams and we're not really saying what we're doing, but to really hear what you're thinking and where as you're going down, really, really important to go through and very helpful for the entire team. So once we complete our primary survey, we want to ask a few more questions. This is where we have a moment, now that we've really assessed our patient for life-threatening injuries, to think about what are the historical factors that matter here. So we learned in ATLS that the ample history is what we're going for. We want to get to allergies. We want to know if they're on any medications. We want to know about past medical surgical history. We want to know about last meal, menses, last tetanus shot, and what happened. This is our time to be a detective, to really think about whether we have in mind what happened in this particular trauma mechanism. And this is where I really encourage you to think like you're a detective. Can I picture in my mind what happened to this patient? Do I have a good enough picture to know what kind of mechanism I'm dealing with? And if it means that we need more questions for the EMS, often, EMS will have a picture for you of what the car looked like, and that's what can be really, really helpful to know sort of what that risk is. Often, the way it was described, you're like, no, it doesn't sound that bad. Then you see the car, you're like, whoa, that passenger side or that driver's side is completely crushed. So having a really good idea, as best as you can, to know what happened to this trauma patient can be really helpful. Now, what about lab testing in the trauma patients? Many of us have sort of what we call a trauma panel, and that can include a lot of things. And I would say we want to be as selective about our testing and our imaging. That's one of the take-home messages. Now, if it's a patient who's got multiple trauma, they're going to the ICU, they look really, really sick, this isn't a time where I'm going to say skimp on this or that. But for a lot of trauma patients who are probably going to go home and don't need a full trauma panel, think about what you actually need. And some people, that might just be a pregnancy test and a hemoglobin, and that's really all you need. So in the minor trauma patients, step back and really think about, what do you really need? Is the white count really going to do anything for you? Do you suspect that they have a coagulopathy? Because a lot of patients don't need a full trauma panel. In fact, a lot of patients don't even need an IV. They could get a hemoglobin, a point-of-care finger-stick hemoglobin, and you can trend that. So it really depends on the trauma patient in front of you. But in terms of a sick trauma patient, certainly the lab test that we would think about including would be a pregnancy test, a hemoglobin, a glucose, of course. If you have iStat or point-of-care chemistry available to you, that might be helpful. Doing a basic metabolic panel, coagulations, thinking about a type and screen or a type and cross, depending on what they might need. Considering what kind of toxicologic tests, we could get into a long discussion about whether you should be sending alcohol levels or not on trauma patients, and there's a lot to say about that. In general, my practice is not to send an alcohol level unless I think it's going to make a difference in the decision making. If there's really a question about an altered trauma patient and how that might be contributed to by the toxicologic testing, but it's not a reflex test that I generally send. Considering a UA, an EKG, other tests like troponin, for example, an older person in a single vehicle MVA, was it a heart attack that made the car crash? Was it a stroke that made the car crash? You may be in the middle of a medical workup in addition to your trauma workup. So keeping those things in mind and using those extra tests selectively. So what about imaging? What kind of imaging are we going to do? Well, of course, that's going to depend on the patient in front of you, where they're tender, what the mechanism was like, but certainly there's still a role for plain films. Doing a quick chest x-ray can be really, really important. Doing a quick pelvis plain film might be also very important in terms of determining etiologies of hypotension or tachycardia. Knowing that they have a smashed pelvis or sooner rather than later may be a really important part of that patient's trauma resuscitation. What about the pan scan? Certainly if you go to a big trauma center these days, you are finding that patients are just getting a CT of everything. And I feel like we are moving in a direction where we're pushing back a little bit and being a little more selective about the CAT scans that we're doing. And I think that's a good thing, particularly in pediatric patients, where we really need to think about what we're CTing and why we're doing it. And I do think it's our role in emergency medicine to push back on trauma consultants who want to just pan scan kids for just because, you know, don't give me just because. What exactly are you worried about? And let's talk about selective CT scanning, especially of pediatric patients. If it's a patient who's 90 years old, I'm not going to argue as much about the radiation, of course. But I'm talking about a kid, I'm not going to let you just pan scan them unless I'm really worried and it's undifferentiated to me in terms of what kind of injuries could be there. Now, patients may also need special studies. They may need a CT angiogram of an extremity, for example. And if we think that there might be a spinal cord injury, an MRI might be in their near future. And these things all matter in terms of our decision-making about this patient who's still dynamically changing in front of us, leaving our care and going to a CT scanner or some kind of imaging. Thinking about their care and not sending them to the tunnel of death and CT scan without thinking about their airway and what they might need there, and not letting them just go there alone. So the secondary survey will follow the primary survey. This is a head-to-toe exam. This is where you really get detailed and thorough, looking in the hair, doing a complete neuro exam, getting a lot more detail. This is your head-to-toe exam, including neuro, where you take your time and you go through every little detail. That would include a detailed exam of the head, the eyes, the ears, the nose, looking in all of these places, the chest, the abdomen, the pelvis, all of the extremities, looking at the wounds, defining them, describing them, deciding what their management is going to be. And this phase of care may involve splinting. This may involve fracture reduction, and wound exploration and repair may be also part of this phase before they move on to the next part of care. Now, often in trauma, we deal with agitated patients, and this can be a really challenging thing, and it's a very common scenario in trauma. And behavior control is really important, not just for safety of staff, that's certainly part of the consideration, but in general, often that patient who's very agitated because of the head injury that they have versus the alcohol or drugs that might be on board is preventing the care of themselves. They're preventing that CT scan that's really important. They're preventing the care of themselves. And so the behavior control is about facilitating their care for their own protection. There are various approaches to do this, but keep in mind that trauma patients are always at the potential for having hypotension. We have to always keep that in mind. We don't know, we don't have a crystal ball to know where that blood pressure is going to be in 10 or 15 minutes. And often if we're going to be adding sedation agents, keeping in mind that alcohol and drugs might be on board and what we think might be going on and choosing the right agent. The ultimate control of a very agitated, sick trauma patient is to paralyze them, intubate them, and get done what needs to get done. And that is certainly the ultimate control, and sometimes we get there. We have to also look for what might be making them agitated. It could be their injuries, it could be a full bladder, it could be glass on the back of the board or tape from the backboard pulling their hair. Is there some kind of noxious stimuli that we can deal with to also get that agitation down a notch? It might be pain control that you need. Agitation can also just come from pain. And so adding a little opioid can really certainly help the patient who's got the fracture, who's got a painful injury that may also be causing them not to follow directions and be agitated. So it might just be pain control more than Haldol or some kind of benzo to control their behavior. But certainly if we're dealing with a patient who's intoxicated with drugs or alcohol, these are kind of, to me, the main drugs that we go to. We're going to something like haloperidol, lorazepam, and even these days we're considering ketamine in some of our trauma patients to really get control. So all of these can be options. Now, in terms of pediatric trauma, keep in mind that they obviously have vital sign differences. It's very, very helpful to have this information, on a wall in the room that you do for your pediatric trauma, to keep in mind those vital sign differences. They have different airway considerations, of course. Broslow tape should definitely be ready to go and part of your trauma room. And I would add, in terms of the ABCDEs for pediatric patients, an F for family. Keeping in mind where the family is, having them in the room can be certainly very, very helpful in terms of controlling the very scared pediatric patient in a trauma setting. And so locating family, if this happened at school or somewhere else, is also going to be really, really important. So family there as well. So a summary here: trauma care requires a leader. We are that leader. We are the team leader, and this is a team sport. Letting everybody know what our expectations are, speaking out loud as we go through our primary survey to let everybody know that we're on the same page is really important. That primary survey is key. Keeping focused, not getting distracted, dealing with one thing at a time, thinking about what we can do to temporize, looking for signs of life-threatening injury and dealing with them, always assuming that there might be a C-spine injury until proven otherwise, and keeping systematic and organized so we don't overlook a potentially life-threatening injury that pops its ugly head up later. We're like, oh God, if I had just done this one thing. So keeping organized will prevent us from getting to that point. Thank you very much.